I'm a medical student, and it's sort of aimed at medical students, so just keep that in mind, and like always refer to local guidelines, etc., before using what I've said in clinical practice, because I know we get a bit of a mix in this audience. So there's a QR code on the right. As Vanya said, feel free to ask questions in the chat, or if you feel more comfortable, you can scan that QR code, and you'll be able to ask them anonymously if you don't want to put your name to the questions, essentially. So I'll give you a few seconds to do that. Cool. So this is just a bit of an overview of what we're going to talk about. So we're going to first talk about types of burns and causes of burns. We're going to then talk about local and systemic effects of burns, first aid management, or your initial sort of management of burns. Then going to talk about the A to E assessment, estimating depth of burns and calculating the percentage of total body surface area affected, and also going to touch on fluid resuscitation and a bit about sort of burn care provision and when to refer to specialist care. Cool. So I was just wondering if anyone could put in the chat any types of burns they can think of. Yes, there's a few really good answers there already. If you talk about depths of burns, which we'll cover in a bit. So definition of a burn is just any sort of traumatic injury to skin or other tissue primarily caused by thermal or another sort of acute exposure. So the first one I've got down here is a thermal burn. That's probably what we most commonly think of. You can further sort of classify this down into like flame burns, contact burns, and scalds from hot liquids. And they're also the most common type. Then got chemical burns, which could be from like household products or industrial things, with cement being a reasonably common one. Important to note that like this will continue to burn the skin until you effectively irrigate the area, so you need to really wash all the chemical off before you do anything else. Next I've got down is electrical burns. So as a current enters the body, it'll have like an entry point and an exit point. Between those two areas, the electricity will be turned into like thermal energy, which can obviously lead to burns. You can also get other associated problems such as arrhythmias. Next one, we've got like frostbite or cold exposure. So once your tissues get really, really cold, you start getting the formation of these crystals, which essentially damages tissue and causes its sort of own unique form of burn. And with these, you need to sort of rewarm them slowly in a wet environment, such as like a bath or something like that. And then the last one I've got down is radiation burns, which are luckily pretty rare. Most common one actually is probably sunburn, if you count that. I mean, you can get burns from things like radiotherapy for cancer treatment as well. So as we said, thermal burns are the most common. The type of burn also changes with the population, with sort of scalds being more common in children, and contact burns being especially more common in older adults, and flame type burns being the most common in like the normal adult population. So now we're going to talk about like the local effects of burns. Pardon me. And this is like the Jackson's burn model. So there's three main areas to a burn according to the Jackson's burn model. So you've first got the middle bit here, which is in dark grey, the coagulative necrosis area. And this is the area sort of closest to the contact with the exposure, whether that be thermal, chemical, or whatever. And in this area, proteins have coagulated and the damage is irreversible, so that tissue is dead and there's nothing you can do about it. You've then got this sort of white or lighter grey area around it, the zone of stasis. And in this area, there's sort of poor tissue perfusion, but if managed properly, you might be able to save some of that tissue. Then around it, you've got the area of hyperemia. We've got increased perfusion due to an inflammatory process. And again, this tissue is potentially viable if it's treated properly. So it's important to keep this in mind, because obviously if the burns aren't treated adequately, then the area of the burn is going to increase over a few days. So if you treat the burn properly from the beginning, then you can potentially reduce the amount of burden or area burns. So we've quickly gone over like the local effects of burns. So we'll talk about some of the systemic responses you can get to larger burns or major burns. So damage caused to tissue by the burns leads to release of inflammatory cytokines and mediators. And if that's extensive enough, you start to get some systemic effects. So once you get to about 15 to 20% of someone's total body surface area, these inflammatory mediators lead to systemic effects and affect other areas of the body. So it has effects on the cardiovascular system. So you get an increase in permeability of the capillaries, leading to movement of fluid into the interstitial space in the sort of similar way to sepsis. You get this third spacing of fluid, and you also get a decrease in cardiac contractility, so your heart doesn't pump as effectively. When these two factors are sort of coupled with fluid loss that you get in major burns patients due to the loss of the natural skin barrier, they're often significantly hypovolemic and poorly perfused, and hence fluid resuscitation is a really important aspect of their care, which we'll touch on later. Next is the respiratory system. So those inflammatory mediators can cause bronchoconstriction and cause issues with ventilation. You can also get something called acute respiratory distress syndrome, which we won't get into too much detail about today, but it's essentially acute diffuse inflammatory lung injury. It's characterized by increased vascular permeability and leads to significant hypoxia. And then you can also get airway compromise from the burns, either directly due to the heat or smoke, or you can get secondary airway compromise because of edema because of these systemic effects on the release of the cytokines, essentially. And then we've got a few other things to keep in mind. So when someone's had major burns, their basal metabolic rate increases significantly, about 3 times above their baseline. You also get decreased gut perfusion due to vasoconstriction of the splanchnic nerves. Because of these two factors, early sort of enteral feeding, say through an NG tube, is really important. You also get down-regulation of the immune system, that's sort of non-specific. And when you couple this with the patients losing their normal sort of protective barrier of the skin, then they're very susceptible to infections and sepsis. Cool, so we're going to quickly touch on burns first aid. Since thermal is what's most commonly encountered, this is probably what we're going to focus on the most. If you're interested in finding out a bit more about like first aid for like chemical burns, etc., then that link at the bottom right there has a few good little guidelines. Cool, so prompt, effective first aid for burns has been shown to lead to significantly better outcomes. And burns first aid is effective for up to 3 hours after the injury. So if you see someone in the A&E department and they haven't had basic sort of first aid and cooling, then you should still go ahead and do that if it's within that window. On placement, I've seen sort of like the plastics team come down and they've sort of run people's hands under taps and stuff, which sort of highlights that it's probably quite effective if they're bothering to do it that late on. So the first step is to stop the burning process. You can either do this by removing the source from the person or the person from the source. The next thing is to remove any clothing or jewellery, but if clothes are sort of molten and stuck onto the patient, it might be best leaving these so that it can be taken off in theatre to avoid tearing skin and causing unnecessary trauma. Next is to cool the burn. It should be done as soon as possible. So in the pre-hospital setting, you want to do this before going to hospital or whatever your definitive treatment is, unless it's absolutely necessary to ship the patient out straight away. So you need to cool the area that's burnt under cold running water for 20 minutes. As mentioned, this is usually done before they get to a hospital. If you're going to cool a large area, it's important to try and keep the patient warm as well and avoid hypothermia. If there's no running water, you can use like cold compresses or just make do with what you got, like a bag of saline, and run that over or whatever. Next bit is just to keep the patient warm, because they're very susceptible to becoming hypothermic if there's a large area burn, or if you're cooling the burn as well. And the last is covering the burn. So I was wondering if anyone could put in the chat what we generally use, like for first aid for covering burns. Yeah, cling film. That's great. So someone's messaged me, what's the third thing? And I think that was just to be cooling down of the burn. So running the burn under cool running water for 20 minutes if possible. So I don't know if there are any questions before we move on to the next section.
Yeah, there were a couple of questions. Someone asked if the BMR increases, would calorific intake be considered?
Yeah, definitely. So that's what I was trying to mention earlier. So early enteral feeding through an NG tube, for example, is really important in these patients. So you don't want to hold off as you might do in your some of your ICU patients where you don't feed them for 2 or 3 days. You want to get calories in early because we really need that for recovery.
Okay, and then someone else was asking, I think with your diagram showing the area of stasis, they said what will be there in the area of stasis?
What will be there?
Yeah.
So it'll be like an area around the main burn, as in visually, or?
I'm not quite sure what they were wanted to know about that one.
So the term stasis just referring to like the blood vessels are relatively destroyed there, so there's not much blood flow there, but the tissue itself isn't actually necrotic and dead. So it's potentially viable, essentially. You might be able to see that visually, or it might just be a theoretical concept. I'm not 100% sure.
Yeah. And then someone's just put, if you put cold water, will it cause blisters to form?
My honest answer is I'm not sure, but that's what's sort of recommended nationally, to put burns under cold running water to help stop the burning process and make sure as little tissue is affected as possible. And if blisters form, it's not the end of the world, because the plastics team usually de-reef them and excise them anyway, because it's just dead tissue at the end of the day.
Yeah. And then someone's just put, why would you use cling film? Would it adhere to the burnt skin, become hard to remove later? Yeah,
so use cling film because it's obviously not like, so if you think of like a normal dressing, it's got like synthetic fibers and stuff, and little fibers will get stuck in the wound. So if you use cling film, it's sort of flat and non-adherent, so you can sort of peel it off without leaving anything else there. So it shows it's covered to stop sort of bacterial infection, as well, sort of prevent fluid loss and heat loss.
Cool. And then last one is, wouldn't cold water further, I'm assuming they're saying worsen the risk of hypothermia, cold water?
Yeah, exactly. So that's what I was trying to mention. Try and keep the patient warm. You just got to balance the two things. So the importance of trying to cool the burn off and keeping the patient warm.
Yeah, that's it. So
cool. So I'll just crack on to the next bit. So now we're going to talk about like the A to E assessment of a major burns patient. So beginning with A for airway. So airways are big concerns in patients with major burns. So there's a few different mechanisms that can lead to airway compromise. Some of them can develop over time, over a number of hours. So it's really important to reassess patients regularly, with others developing quite quickly and maybe with little warning. So it's important to get the anaesthetic team involved really early if you're expecting a major burns patient, or you have one with you. And these patients can be quite difficult to intubate if it's left too late. So often these patients are intubated quite early on. So there's sort of three main mechanisms that can cause airway compromise in major burns patient. So generalized edema can happen if you can get edema elsewhere because of a systemic effect of those cytokines we mentioned earlier. You can get that in the airway, compromising the airway. You get direct thermal injury to the airway, for example, if someone's drank hot liquid or just from the heat of the smoke. And you can also get something called inhalation injury, which happens due to the inhalation of smoke, hot air, or any toxic chemicals. When you get significant hot inhalation injury, sorry, it's quite a high mortality, about 10 to 30%. So there are a few sort of things you can assess for and look out for in initial assessment, which might give clues as to how likely it is that a patient might have airway compromise because of the burns or inhalation injury. So I don't know if anyone knows any or wants to pop any in the chat.
Yeah, so someone's put soot around the nose and mouth.
Yeah, smashing. So that's one of the ones I've got down here. I've got a few others as well. So a hoarse voice or stridor, any facial burns or burns to the upper torso or neck. So black sort of sputum from the sort of carbon deposits from the soot, swelling of the oropharynx on quick visualization, sustained burns from being enclosed in a space such as a house fire, and if there's any sort of evidence of respiratory distress. So that was really good. Cool, now moving on to B. So there's, again, another sort of significant concern in burns patients. There's a few different ways that ventilation and gas exchange can be impaired. So you can get direct damage to the lower airways and alveoli from inhalation injury in a similar way to the upper airway. You can get carbon monoxide poisoning, especially if they're stuck in a fire and enclosed space, such as a house, which obviously impairs your hemoglobin oxygen carrying capacity. And then if there are burns to the torso, then this can actually stop effective ventilation. So you can get, so when tissue's burnt, you lose that sort of normal elasticity, and you get a sort of like leathery sort of tissue that constricts the chest and might stop normal chest rise for effective ventilation. And if this is the case, then we might need something called escharotomy, which is essentially where you cut through the burnt tissue or the eschar to allow the chest wall to sort of move normally. So on assessment, you're going to do your usual stuff, respiratory rate, SATs, tracking the trachea, auscultation, etc. Really important to fully expose the chest, looking for burns, in particular sort of circumferential burns that go over the whole way around the chest. Also need to look at like chest wall movement, see if it's reduced or reduced on one side. If there's any concern about the airway, about breathing, then you need to do an ABG quite early on. Keeping in mind that the hypoxia might not be as detectable on a peripheral SATs probe if they've got carbon monoxide poisoning. If SATs are fine and you're not too concerned, then a VBG might be sufficient. But remember that the VBG or the ABG can give you the sort of carbon monoxide level, which helps you rule that out quickly. Also important to consider chest wall injuries, because these patients are highly associated with trauma situations, for example, like trying to escape a fire and jumping out a window, etc. And also being aware of things like cyanide poisoning, which we're not going to cover today, but essentially like cyanide can be released from household items being burnt. So there's a picture of like an escharotomy in the next slide, so it's a bit gruesome. So if you're not into that sort of thing and it's a bit uncomfortable with it, then feel free to look away. So this just shows an escharotomy. So the sort of burnt tissue is cut through to ensure the chest sort of ventilates, moves effectively for ventilation. They also sometimes do these for the limbs, so the legs and the arms, if there's circumferential burns there, because it can lead to compartment syndrome, essentially. So on to C. So as we mentioned, when we talked about systemic effect of burns, patients are at quite a higher risk of hypovolemia and shock. In most cases, you need quite aggressive fluid resuscitation. Once you get to about 15% of total body surface area in adults or 10% in children, which we'll cover a bit later. We'll also cover like how to estimate total body surface area. So you're going to do your usual sort of cardiovascular assessment. Important to not perform the cap refill on like a burnt area tissue because it would be abnormal because of that. Also important to like check the distal pulses, because as we just mentioned, you can get compartment syndrome and sort of circumferential burns that stop circulation to the distal limb. What else is there? Early IV access, really important if you need to give large amounts of fluids to the patients, and you might want to do that early before sort of significant edema develops. If there's any sort of problem with that, you can just go straight for an IO. Intraosseous access is where you put a big needle into either the proximal tibia or the deltoid, not the deltoid, the proximal humerus, sorry, to give fluid. And then obviously consider your other causes of shock if they're shocked as well. As we mentioned, there's an association with trauma in these patients. So moving on to D and E. So it's important to sort of assess D as you usually would, so GCS, pupils, maybe a brief neuro exam, just to ensure that there's no other sort of associated injuries causing a reduced GCS, so they might have it because of a compromised airway, for example. And then exposure, so it's important to try and calculate the total body surface area affected by the burns as effectively as possible, as accurately as possible, because it dictates how much fluid they get, and it's good for sort of communicating with specialties and describing how extensive the burns are. We'll look into how you do this in the next few slides. And as we mentioned earlier, patients are really susceptible to becoming hypothermic. So maybe just sort of like expose one area at a time, do one area of the body at a time, try and keep them warm. Maybe thinking about getting all these specialities involved there at the same time, so you have to fully expose the patient once. And also important to do a sort of normal primary survey to assess for any other peripheral injuries, because as we mentioned, there might be trauma involved. Cool, so before we move on to the next bit, does anyone have any questions they want to ask?
Yeah, I think someone asked, why is it it's intraosseous? Why do they go into the bone?
So you wouldn't have to. It's just more from the aspect that major burns patients need a lot of fluids. So if you're struggling with IV access, you can only get sort of a diddly little blue cannula in. You might be best just going for IO access. You can give a decent amount of fluid because you've got that large bore needle, that's all. Obviously, if it's quite extensive burns as well, it might be quite hard to get IV access.
And someone asked about rule of nines.
Yeah, so I'll cover that in the next few slides, yeah, no problem.
Yeah. And then they said, can you explain again why the burnt guy from the picture looked like that? So why he had the escheriectomy, the different areas?
Yeah, no problem. So he's got quite extensive burns to his sort of chest and neck up here, which look like they're probably full thickness, I think, from the discoloration, the sort of leathery texture to it. So when you get skin burnt to this extent, it becomes sort of leathery and hard and doesn't stretch as normal. So this means your chest wall isn't going to rise and drop as it usually would to ventilate efficiently. So what we've done is cut through the burnt skin, which is also called like an eschar once it becomes sort of rubbery and hard, to allow the chest to sort of move normally. So that's just called like an escharotomy. Hopefully that helps a bit. If not, I can try and go over it again.
Yep, they said thanks. That's it.
Cool. No problem. So shall I crack on, or any others?
Yep, that's it.
Smash it. So now we're going to talk a bit about estimating the percentage of total body surface area affected by a burn. So as we mentioned, it's really important to try and do this reasonably accurately. Dictates how much fluid is given, and also sort of dictates whether you need specialist involvement for the smaller burns. And it also helps you predict the physiological response, because as we mentioned, the higher the sort of total body surface area, the higher the chance of that sort of systemic response to major burns. And it's often done quite badly, and it's quite hard to do. They say that it's best done in theatre by a sort of burn surgeon or plastics. but even then they're only sort of accurate within 5%, about 60% of the time. And you only include the sort of deeper burns, so the partial thickness and the full thickness burns, not the sort of erythema or epidermal burns, which we'll cover later, the different types. So there's a few different methods to do this by. And as we mentioned, these are the only sort of thicknesses you should use. So we've already had someone mention the rule of 9. So I was wondering if anyone else could put any other sort of methods of estimating this that they were aware of. Okay, right. So on the left, we've got the rule of 9s, which someone mentioned earlier, the Wallace rule of 9s. So it's quite easy to use and easy to remember. So you might be able to use it in sort of situations where you don't have a chart or access to the internet, for example, like pre-hospitally. So each area of the body is sort of divided into either 9% or a multiple of that. So, well, half, 4.5%. You can sort of add that up to get an estimate. It's not particularly accurate, with some sort of studies saying it overestimates by about 20%, and it shouldn't be used in children, so it's only for adults, that one. And then the next one we've got is the London Browder chart. I don't know if anyone's heard of this one, but this is generally what's used in hospitals. Bit more accurate, but it's quite not hard to use, but there's a bit more to it, so you need to do a bit more maths. And there are specific charts for different age groups, so adults and children, and it divides the body into sort of different areas, given different percentages, and you add that up to get the total area. And on the right, there's a rough rule as well, which is that the patient's palm is roughly 1% of their total body surface area, so that's their palm and not yours. So you can use that to sort of estimate the area of smaller burns in particular, might be useful in children, for example, but it shouldn't be used for sort of larger burns, I would say like 10% or so. There's also this app, which I've seen being used a bit. It's called like the Mersey Burns app. And this is just a screenshot from it. So it essentially has like a silhouette of a man or woman. And then you sort of colour in the area affected by the burn. You can choose different sort of colours for full thickness and partial thickness. And there's a little study saying that it might be more accurate. And it gives information on fluid resuscitation as well. You just put in the age of the patient and the weight. So that's quite handy. Okay, now we're going to quickly go over like depth of burns. So there are 4 main types. No longer used for first, second, and third degree. As burns are often sort of homogeneous, with different depths of the burn being in the same area or next to each other, and can be dynamic as well. So over a couple of days, as we mentioned, burns can sort of progress and become worse. So it might start with a superficial partial thickness, for example, and become full thickness. Realistically, it's quite hard to do this accurately. You should obviously just try and do it to help with communication with specialties, etc. So first one being epidermal burn, where only the epidermis is affected. So you get redness but no blistering, and it blanches to pressure. So it goes sort of white or paler with pressure, often sort of temporary and heals quickly, will heal without scarring. And important to remember, you don't include this when you're estimating total body surface area that's burnt. Best way of remembering this one is just thinking of your classic sort of sunburn, essentially. So the next is superficial partial thickness. So this is when the epidermis and the upper layer of the dermis is affected, and it's usually sort of pale pink and painful. You can get some blistering. Cap refill is normally quite brisk or can be normal. And it takes a bit longer to heal, so about 2 to 4 weeks. So I've got a video here. I'm not sure if it'll play, but we'll give it a go. And this is of a superficial partial thickness burn. So you can see it's sort of pale pink, quite bright, and that cap refill's really brisk to return. We'll just play a bit of that quickly. So cap refill comes back straight away, and it's sort of pale pink and bright. Cool. So the next one's deep partial thickness burns. So this is when the deep and superficial layers of the dermis, as well the epidermis, is affected. It's often quite blotchy or cherry red, can be painful, can be painless, might have blisters present as well. The cap refill time with this one either only blanches fully and returns with a really slow, sluggish return, or it might just not blanch at all and stay red and sort of cherry red. Healing will take a bit longer for this one, so about 6 weeks, and it often needs grafting, so needs surgical input. So this is a video of a deep dermal burn, deep partial thickness burn. So as you can see, there's no real cap refill there. It's sort of cherry red, looks sort of hot and wet, essentially. Cool. And then the next one being full thickness burn. So this is when the burn extends into the subcutaneous tissue, skin appears dry and discolored, white, brown, or black. Don't get any blisters, looks sort of waxy and leathery, generally painless, and cap refill, it doesn't blanch at all. And this will definitely require surgical intervention. So this is a video of that. So the area is sort of discolored, white, pale, looks sort of hard and leathery, and there's no sort of cap refill. So hopefully that's reasonably useful. I don't know if anyone's got any quick questions before we move on to the next bit.
No, there's no questions in the chat. Oh, hang on. Is it harder to assess thickness burns in coloured individuals?
I don't know, if I'm completely honest. I'd imagine, I mean, in the same way as sort of classic sort of dermatology teaching of it, there's obviously been a deficiency in that, and a lot of the textbook examples and stuff are in white individuals. So that might be something to, yeah, definitely look into.
Yeah, that's the only question.
Yeah, no worries. I'll crack on if that's all right. So we're going to talk about fluid resuscitation now. So as we mentioned, there's sort of large fluid deficits in these patients. That increases with larger surface area that's burnt. And because due to sort of increasing insensible losses, so you lose that natural skin barrier, so you get sort of fluid leaving through the body as in a way it wouldn't usually do. As we mentioned, you get that sort of third spacing of fluid into the interstitial space and reduced cardiac contractility, which contributes to the shock as well. And the maximum sort of hypovolemia, the intravascular hypovolemia, is said to like classically occur between like 8 and 12 hours after the injury. So it's really important to give adequate fluids to these patients. If you look into the literature, there's also a thing about fluid creep and how often these patients are given too much fluids, which can cause its own sort of problems, such as worsening edema, might actually devitalize some of that potentially viable tissue, risks of things like cerebral edema and stuff like that. So it's important to give adequate fluids but not go overboard as well. Also important to note that generally they say you shouldn't give large boluses really quickly unless you have to, because that can basically precipitate compartment syndrome and cause sort of volume expansion too quickly. So generally use Hartmann's or Plasmolite or a balanced crystalloid over normal saline or 0.9% sodium chloride. That's because you're going to be giving these patients large volumes of fluids, If you give someone lots of normal saline, they can cause them to become acidotic, essentially, through something called hyperchloremic acidosis, which might be something that's worth looking up if you haven't never heard of it before. So catheterization early on in these patients is really important because it can help with that fluid resuscitation and make sure you're sort of getting the right sort of urine output. And important to note that you only need to use this formula that I'm going to show you, or specialized sort of fluid resuscitation, beyond what you'd usually give once there's about 15% of the total body surface area affected in adults and about 10% in the pediatric population. Cool, so I'm going to talk about a formula that's usually used for fluid resuscitation. I don't know if anyone's heard of it, or we can put the name of it in the chat.
Yeah, someone's put Parkland's formula.
Yeah, smashing, so that's right. So we'll go through that quickly now. So this is the Parkland formula, which is actually quite straightforward. Like, I thought it was confusing when I first looked at it, but there's not much to it. So this is what's most commonly used to estimate how much volume you need to give to someone in a 24-hour period. As we said, you should only start using it once there's over 15% of the total body surface area burn in adults or 10% in children. So it's 4 mils times by the body surface area affected by the burn times by weight in kilograms. This 4 mils is sometimes changed into 3 mils generally for children, and some trusts use 3 mils for adults as well to avoid that issue of giving too much fluids. So once you've calculated how much they need over 24 hours by doing 4 mils times surface area times by the weight, you divide that into 2. You give the first half over 8 hours and the next over 16 hours. So it's important to know that first 8 hours is the 8 hours from the injury itself, not from when they get to hospital. So you might need to give that volume over a shorter period than 8 hours if there's been a significant delay. Another important thing to remember is this should be in addition to their normal maintenance fluids if they're not taking anything on orally. Cool, so we're going to use a quick case just to go through that. So Terry, 28-year-old man's caught in a house fire, jumps out of the window to escape. On arrival to the ED, primary survey reveals only a lower limb fracture, no sort of life-threatening injuries or any airway concerns. You expect there to be 22% of the total body surface area affected by the burns. And you ask him how much he weighs, and he said he weighed himself last week and he was about 75 kilos, which is very handy. So we're now going to sort of calculate how much fluid he needs over a 24-hour period, and how much needs to be given over the first 8 hours, and how much needs to be given over the subsequent 16 hours. So starting off with the first bit of the Parkland formula, which is just 4 mils, which is the same for all adults, or 3 mils in children. Then I'm going to multiply that by the percentage of total body surface area affected by the burns, which in this case you've estimated to be 22%. Then you're going to multiply that again by 75, which is his weight in kilograms, which gives you 6,600 mils or 6.6 litres. As we mentioned, you're going to divide this into 2, which gives you 3.3 litres times 2. So half of that's going to be given over the first 8 hours from injury, so 3.3 litres over 8 hours. You're then going to give the other 3.3 litres over the next 16 hours. And then, as we mentioned, think about maintenance fluids as well if you need to. Cool, so that's fluid resuscitation. I'm just going to quickly talk about like burn care provision and like communicating with specialties. So in the UK, burn services are divided into like 3 tiers. So you've got burns facilities. So these sort of advise and treat patients with small or less serious burns. And it's usually part of like a local plastic surgery service. Then got burn units that treat most patients that need admittings for hospitals for their burns. And there's 1 in each region of the UK. So if you're based in Liverpool, it's Wiston, I believe. You've then got burn centres as well. So they've got like the most advanced sort of intensive care treatments for these sort of patients, and cover larger areas. I'm not sure how many there are in the UK, but I'm assuming there's only a handful. Many of the burn centres will also be burn units for the local area as well. So really important to sort of refer to your local guidelines and pathways when thinking about who you should refer to these specialist services. So I've got a slide now. I sort of give some examples. So I stole this from like the London Burn Service about which patients they believe should be referred straight away. So things like anyone with over 3% affected, or any children with over 2% affected, any full thickness burns, any suspicion of inhalation injury, if there's burns to specific areas like the face or the genitals, things like chemical or electrical burns, things like acid burns, stuff like that. Obviously, it's really important to think about NAI, non-accidental injury, especially in children and vulnerable adults. So NICE have a guideline on like when to suspect NAI and burns in children, which might be worth having a glance at. So this is just something to be aware about, but definitely not sort of memorise off the top of your head. Cool. So that's everything I've got to cover today. If there's any more questions, I'll be more than happy to have a crack at answering them.